I would like to give a presentation on neurogenic bladder as from the perspective of a urologist who commonly treats these conditions. So what defines neurogenic voiding dysfunction or neurogenic bladder? It's an abnormality in storing or voiding function of the bladder as a result of a relevant neurologic disturbance, that is to say, a relevant neurological lesion that can affect bladder function and result in bladder dysfunction. And this must be confirmed by an objective evidence of a clinically relevant nervous system disorder. Patterns of neurogenic voiding dysfunction are often predicted by the level and type of injury and disease, but not invariably so. Such patterns can be limited by the completeness or incompleteness of the lesion, the progression of the condition, and furthermore, the patterns of neurogenic voiding dysfunction may be compromised by the external to the urinary tract factors of the neurological disease, such as cognitive dysfunction or coexisting urologic disease, such as benign prostatic disease or stress incontinence, as well as other comorbidities throughout the body that can affect urinary functions, such as diabetes and congestive heart failure. In order to understand these patterns of voiding dysfunction, it's important to understand how the neuraxis and the urinary tract interact. The cerebral cortex is critical to voiding function. The frontal lobes and cingulate gyrus initiate voluntary voiding, and they also inhibit reflex voluntary voiding. In general, all suprapontine structures, the cortex, basal ganglia, cerebellum, and the rest of the brain above the pons, are inhibitory on urination, and when these structures are injured or diseased, some of the inhibition is released. When we release inhibition on the lower urinary tract, the bladder tends to be overactive, and that is to say, results in the symptoms of urinary frequency, urgency, and urge incontinence. So any suprapontine lesion can result, or often results, in the finding of urinary frequency and urgency. The pons is generally considered the area where, or the pontine micturition center is generally considered the area that contributes to the coordination of the bladder outlet and sphincter and the bladder. That is, the pons allows the coordination of these two structures during urination as well as during storage of urine. There's afferent input ascending through the spinal cord as well as descending. There's efferent outflow from the descending spinal cord. And any type of injury that separate the pons from the lower urinary tract, such as spinal cord injury or multiple sclerosis, results in characteristic reflex voiding patterns. The micturition center at the level of S3 with afferent and efferent limbs leading to parasympathetic and somatic innervation of the bladder and pelvic floor are then affected by lesions above this reflex arc in the spinal cord and the cortex. The patterns of neurogenic voiding dysfunction can be broken down into three general categories. Lesions above the brainstem, which result in detrusor overactivity with coordinated voiding, that is, no external sphincter dyssynergia. These patients generally have frequency and urgency. Then there's lesions between the brainstem and the spinal cord, which results in detrusor overactivity, but also generally a loss of sensation and a discoordinated sphincter, resulting in incomplete bladder emptying, as well as autonomic dysreflexia in lesions above the level of T6. And the third pattern of neurogenic voiding dysfunction are lesions of the sacral spinal cord and distal spinal cord, the peripheral nervous system, which results in detrusor areflexia, that is, a bladder that does not contract, as well as often a decreased non-relaxing sphincter function. The incidence of bladder dysfunction varies considerably, again, with the lesion, the type of lesion, the progression of the lesion. In spinal cord injury, the incidence of bladder dysfunction can be as high as 70 or 80%. In multiple sclerosis, generally we quote about a 3/4 to 80% incidence of voiding dysfunction in patients with multiple sclerosis. Patients with myelodysplastic syndrome can have voiding dysfunction in up to 3/4 of individuals. Parkinson's disease can have voiding dysfunction in up to 1/3. Diabetes does affect the urinary tract both acutely and chronically and can have voiding dysfunction as a result in up to 1/3 of individuals. And finally, cerebrovascular disease can have a significant impact on lower urinary tract function in 10 to 20% of people. The goals of a neurogenic voiding dysfunction evaluation include an accurate assessment and diagnosis and characterization of the voiding dysfunction, and then a reassessment as symptoms change. Also, a recognition of concomitant non-neurogenic voiding dysfunction that exists within the urinary tract, such as BPH and stress incontinence. Secondarily, we want to assess the prognosis, as certain conditions are associated with a poor prognosis with respect to the urinary tract. Such conditions can be spinal cord injury and diabetes. And then the third aspect of the goals of neurogenic voiding dysfunction are to direct treatment and management and individualize this treatment. The so-called neurourological evaluation consists of a history to characterize the type of voiding dysfunction and symptoms, a physical examination including a neurological evaluation and examination of the appropriate spinal segments and dermatomes and myotomes, an assessment of post-void residual, a serum creatinine to assess kidney function, urine analysis, and culture, an upper tract study when indicated in those conditions that have high risk of upper tract deterioration due to lower urinary tract storage abnormalities, a urodynamic study to assess pressures in the lower urinary tract, and then a cystoscopy when indicated for abnormal urine studies and a variety of other reasons. When we look at treatment from a 30,000-foot view in neurogenic voiding dysfunction, we look at assessing safety first, that is assessing the risk to the upper urinary tract, the kidneys. Those risk factors include anything that results in increased pressure in the lower urinary tract, such as impaired compliance, that is a bladder that's inelastic, vesicoureteral reflux, recurrent urinary tract infections, and the like. And then we concentrate on relieving symptoms secondarily. Often these patients do have significant symptoms, and we would like to relieve their symptoms, but first we assess their risk, and then if they have a low risk, we then attempt to relieve their symptoms, which could include incontinence, frequency, urgency, or a variety of other lower urinary tract symptoms. The goals of management are to preserve the upper urinary tract or to reverse deteriorating renal function due to lower urinary tract storage abnormalities. We want to control infection, preserve or create urinary continence, reduce or eliminate the impact on the quality of life, and then finally make an acceptable solution for the patient with respect to their physical needs, their economic capabilities, their social and cultural needs. We achieve these goals by providing adequate urine storage at low pressures, by providing adequate emptying in the absence of obstruction, by providing adequate urethral closure function to prevent stress incontinence, selecting the least invasive, least expensive option, and then individualizing management. So let's break into the three categories of lesions with respect to the neuraxis. Lesions above the pons, that is, such lesions as brain tumors, dementia, or stroke, usually result in the clinical symptoms of urinary frequency and urgency, sometimes urgency incontinence, usually satisfactory bladder emptying, and usually normal or low risk to the upper urinary tract. If we do urodynamics on these individuals, we find detrusor overactivity, which is the urodynamic term for the finding of involuntary bladder contractions. The sphincters are generally synergic. There's normally preserved sensation, and bladder emptying is usually normal because there is preserved coordination between the bladder and the sphincter. There's a variety of Other CNS disorders which result in this pattern of satisfactory emptying and bladder overactivity resulting in frequency and urgency, and here is a partial list of those lesions. The treatment of lesions above the pons, that is cerebrovascular accident, dementia, others, is to reduce the bladder overactivity that results in the patient's symptoms of frequency and urgency. And the way we do that is generally with behavioral modification, oral medications such as antimuscarinics or beta-3 agonists, which result in smooth muscle relaxation and can prolong the voiding interval and reduce bladder contractility, thus reducing symptoms. And occasionally in these people we'll resort to sacral neuromodulation, a sacral nerve stimulator at sacral root S3. Sometimes we have to inject botulinum toxin at doses of 100 units or 200 units every 6 months or so to reduce bladder overactivity. And in rare instances, we have to resort to augmentation cystoplasty, which is enlarging the bladder using either ileum or colon to make a larger reservoir and reduce the bladder overactivity by disrupting the smooth muscle of the bladder and interposing large or small bowel, creating a larger reservoir. The second category of lesions are lesions between the pons and sacral spinal cord. These include commonly multiple sclerosis, traumatic spinal cord injury, transverse myelitis, and a variety of other spinal cord conditions. These patients usually present with retention, urinary retention, elevated post-void residuals, urinary incontinence, and urinary tract infections. If these lesions are complete, the patient suffers from a lack of sensation of their lower urinary tract. Finally, these are the folks who have significant risk to their upper urinary tract due to elevated storage pressures. When we do urodynamics on these individuals, we often find detrusor overactivity, very similar to the individuals with suprapontine lesions. But in this instance, patients also have discoordinated voiding resulting in strided sphincter dyssynergia or detrusor external sphincter dyssynergia. That is discoordination between the bladder and sphincter resulting in incomplete bladder emptying. And finally, in the long term, these folks can get impaired compliance, and impaired compliance means that the bladder is inelastic during filling, resulting in increased storage pressures. The storage pressure can be transmitted to the upper urinary tract and eventually result in hydronephrosis and renal failure. That is a significant consideration in these patients with spinal cord lesions. In fact, the risk factors for suprasacral spinal cord injury include high intravesical storage pressures generally associated with impaired compliance or vesicoureteral reflux. Such findings can only be diagnosed with urodynamics. There is no other way to assess intravesical storage pressures other than with urodynamics. So in those individuals with spinal cord lesions, they invariably get urodynamics in order to assess their risk factors to the upper urinary tract. Autonomic dysreflexia or autonomic hyperreflexia. This is a unique condition in individuals with spinal cord lesions, generally complete spinal cord lesions. This is a surgical emergency and a medical emergency and a urological emergency. The clinical findings are of a very elevated systolic blood pressure, sometimes approaching 250 systolic to 300 systolic, with a reflex bradycardia down to a heart rate of 30 or 40. Patients get a sense of dread. They get cold and clammy, as well as sweaty above and below the lesion, respectively. This occurs in spinal cord lesions above T6 to T8, where the autonomic, when the lesions are above the location of the sympathetic input back into the spinal cord from the lower viscera and lower extremities. The autonomic hyperreflexia can occur after the resolution of spinal shock following a spinal cord lesion, but can also occur years later. In order to have this condition, the distal spinal cord needs to be viable. This is often associated with strided sphincter dyssynergia or detrusor external sphincter dyssynergia, on urodynamics. The most important take-home point on autonomic dysreflexia is the recognition of this when it occurs and treat it as an emergency, as the patients can have an acute stroke. Precipitating factors for autonomic dysreflexia or hyperreflexia include any insult below the level of T6, below the level of the spinal cord lesion. So this could be a distension of the rectum or a distension of the lower urinary tract, such as that due to urinary retention or a clogged drainage catheter. It can be from lower urinary tract instrumentation from cystoscopy or urodynamics. It can also occur in other organ systems and viscera, such as a distended colon from constipation, a long bone fracture, femur fracture, decubitus ulcer that's either infected or not. Even sexual activity can result in triggering autonomic dysreflexia. The treatment for autonomic dysreflexia is to find and reverse the precipitating stimulus as soon as possible. This can be treated with parenteral ganglionic blockers, alpha blockers, and any other antihypertensive that can drop the blood pressure quickly. Oftentimes in urology, we do procedures under prophylaxis using calcium channel blockers or alpha blockers before a procedure such as urodynamics or cystoscopy, which is known to trigger autonomic hyperreflexia. So generally prophylaxis can reduce the wide swings in blood pressure and pulse if recognized. So treating these spinal cord lesions, the lesions between the pons and sacral spinal cord, the strategy is to reduce bladder overactivity if present, improve emptying, reduce storage pressures, and protect the upper tracts. And generally, this occurs by reducing intravesical pressure, the bladder pressure, by drugs or Botox, or sometimes augmentation cystoplasty, and then getting the bladder empty, usually by bypassing the external sphincter by clean intermittent catheterization, an indwelling suprapubic tube, urethral catheter, or in some instances, complete urinary diversion away from the bladder. The third category of lesions are lesions distal to the spinal cord. This includes lesions such as lumbar disc disease, radical pelvic surgery, and diabetes. These individuals present with frequency and urgency with or without incontinence. They may or may not have urinary retention depending on the lesion and the severity of the lesion. And again, in these folks, because of the possibility of urinary retention and elevated pressures, their upper urinary tract can be at risk. When we do urodynamics, we often find detrusor overactivity or underactivity, that is bladders that either contract too much or don't contract well enough to empty. They can chronically get impaired compliance, which results in upper tract deterioration. Sensation is often preserved, and they generally have no dysynergia, but sometimes can have a non-relaxing external sphincter, resulting in a functional obstruction and poor bladder emptying. For these lesions distal to the spinal cord, the strategy is to improve emptying when problematic, to reduce intravesical storage pressure and protect the upper tracts, and this is generally done by intermittent catheterization if they have poor emptying, and improving compliance either using medications or Botox or another method. So in conclusion, neurogenic bladder represents a complex set of conditions of the central and peripheral nervous system, which can affect urinary function, specifically bladder and sphincter function. A careful evaluation with urodynamics is necessary to assess the type of function, direct treatment, and assess prognosis. Treatment is individualized, and in this group of patients, long-term follow-up is necessary. Thank you.